Hello everyone, my name is Shrutika Yola, and on behalf of the NSGC Education Committee, I want to thank everybody for attending this lecture recording of Community Conversations. Before I jump into today's topic and introduce our panelists, I wanted to reintroduce the concept of community conversations for those who have not attended a previous one, so that you know what our goals are with this format of presentation and learning. Community Conversations is an opportunity for our membership to have safe and brave conversations about critical topics that directly impact our field. With that, we know that these topics can be heavy, yet simultaneously important to discuss. We have adopted a few guidelines from previous community conversations that we ask everyone on this call today to remember throughout this presentation and the live discussion that will occur on April 3rd. First and foremost, be curious and open to learning. Demonstrate respect and suspend judgment. Seek alignment rather than agreement. Welcome authenticity from yourself and others. And respect confidentiality. A couple of housekeeping things before I jump into today's topic and introduce our speakers. As a reminder, this 30-minute didactic portion of Community Conversations is available on the NSGC member webinar page. Anyone interested in this topic has the opportunity to view this lecture and learn from our panelists. With that, CEUs will only be made available for those who attend the live discussion on April 3rd, 2024 at 4 p.m. Central. We ask that those who do attend the live discussion please watch this pre-recorded lecture in its entirety and reflect on the discussion questions. This will help ensure a thoughtful discussion on the live date. Those prompt questions that I mentioned, along with this recording, are available on the NSGC website under the Member Webinar tab. And without further ado, allow me to introduce today's topic and our panelists. The title of our Community Conversations is Acknowledging the Discomfort, Discussing Reproductive Justice Beyond the Prenatal Clinic. Today's learning objectives are: explore methods for initiating difficult conversations about reproductive health, including abortion and family planning, in non-reproductive health spaces. Identify successful strategies from colleagues in protected and non-protected states on ways to address reproductive health options with patients, colleagues, and the community. Discuss real-life examples of successes and challenges in having reproductive health conversations in a variety of genetics and clinical settings. And lastly, navigate ways in which institutional policies can influence reproductive health conversations in the clinical or academic setting. And without further ado, here are our panelists. We have first Samantha Stover. She is a reproductive genetic counselor in the Division of Maternal Fetal Medicine and assistant in obstetrics and gynecology at Vanderbilt University Medical Center. Sam has over a decade's experience providing counseling for patients across the reproductive genetics arc and strongly believes that reproductive autonomy is a core value of the field. As a female genetic counselor with narcolepsy and cataplexy, she lives in the intersection of disability rights, genetics, and reproductive autonomy. Next, we have Katie Bergstrom. Katie is a licensed certified genetic counselor with over 10 years experience in pediatric hematology. She currently practices at Seattle Children's Hospital, serving patients and families with hematologic disorders and leukemia, and is a clinical associate faculty member of the University of Washington. Katie is the 2020 recipient of the National Hemophilia Foundation's Genetic Counselor of the Year Award. Katie has served in several leadership roles within NSGC and has been a passionate volunteer for Planned Parenthood and other reproductive rights organizations since high school. Pilar Margulas is a certified genetic counselor and associate professor in the Department of Molecular and Human Genetics at Texas Children's Hospital and Baylor College of Medicine. She received a Master's of Science degree in genetic counseling from Northwestern University in 2003. She currently works as a pediatric genetic counselor at Texas Children's Hospital, where she serves as the manager of the genetics clinic and chief of the division of genetic counseling. Pilar serves as VP for CFC International, support group for individuals with cardiofaciocutaneous syndrome, on the Scientific Advisory Council for the National Foundation for Ectodermal Dysplasias, and on the Scientific Advisory Board for Rasopathies Network USA. She is passionate about advocacy work and helping families throughout the genetic diagnostic process. And last but not least, Katie Lang is a licensed board-certified genetic counselor. She received a master's in biotechnology from Johns Hopkins University and an MS in genetic counseling from Virginia Commonwealth University. After graduation, she completed a cancer genetic counseling fellowship at Fisher Center for Familial Cancer Research at Georgetown. Katie ran one of the country's largest community hospital-based cancer genetic counseling programs at Northside Hospital in Atlanta before joining the faculty of Vanderbilt. She currently is the medical director of genetic medicine and has run the hereditary cancer clinic at the Vanderbilt Ingram Cancer Center since 2020. Katie is the current chair of the Advocacy Coordinating Committee for NSGC and the co-chair of the Anti-Racism Subcommittee for the Cancer SIG.
Hi everyone, my name is Sam Stover and I'm a reproductive genetic counselor in Nashville, Tennessee. I first want to thank Shrutika for bringing the vision for this community conversation to life, and to Kim Garber with NSGC for all the behind the scenes work, as well as everyone else involved in this process. I also wanted to say thank you to our lovely presenters for sharing their experience of how reproductive justice can come up outside the prenatal space. Reproductive justice spans so many areas of genetic counseling and healthcare, and perspectives of clinicians that are not primarily in reproductive healthcare is incredibly valuable. I'm going to close out our session by providing some tips for those of you who may one day face similar scenarios and are not sure where to begin. I have no disclosures. It's helpful to think of this as what you should always have in your toolkit. In other words, being prepared for some scenarios that are more likely to come up in your area and a basis for how you are going to respond. This also includes who you may need to contact. So my first recommendation is to find allies. This can be a local reproductive GC, an MFM, or another trusted provider that you can call on for advice. If you are in an area where you do not have the ability to make these connections, please remember that some of your biggest allies are on the NSGC SIG discussion boards. I also think it's important to start routinely considering the broader impact of your work and how it might impact patients and reproductive decision making. For example, if you're a peds GC and a new diagnosis is made for a recessive condition, complete the parental testing. This is crucial for families pursuing IVF with PGTM and sometimes even prenatal diagnostic testing. If you are a lab GC and working with prenatal samples, emphasize to colleagues the importance of a tight turnaround time, as decisions may be impacted by these results. Also, maybe consider your lab's policy on DNA retention now that DNA banking options are limited. If you see patients in which a clinical diagnosis is usually made and genetic testing is not performed, such as NF, consider whether they will need an actual genetic testing report in order to pursue certain reproductive options. It's also really important, exploring feelings towards family planning should be done for any reproductively capable person. Every single preconception discussion is an opportunity to determine future plans and/or prevention. Family planning discussions should be routine care. Plant the seed early, even if you feel like a patient is too young. And finally, know what is needed now. Brainstorm some plans for potential scenarios your patients may face. If your patient wants to become pregnant, refer them for a preconception consult with a GC or an MFM or both. Make sure they can have an OBGYN or other reproductive health care provider that they trust. If your patient does not want to become pregnant, Same as above, you can see there's a theme here. Preconception planning is crucial to this and really important. And again, having a provider they can trust to help them with making these decisions is equally as important. If your patient unexpectedly becomes pregnant, for those with a known diagnosis, it is really important to be upfront and ask whether they would want testing for the current pregnancy, because sometimes it takes a lot of coordination, and sadly, it isn't always available even if they have a known diagnosis. Ask whether they have an OBGYN or other obstetrics provider and if they have confirmed their pregnancy. This is especially important because dates can be off and some patients are actually farther along than what they expected, which really impacts testing and many other options. And please put in an ASAP referral to a GC or MFM. That goes for families with a prior affected child, patients with a known diagnosis, patients with other type of family history such as an affected sibling. That ASAP referral is crucial too. I want to emphasize to anyone watching that I am more than happy to try and help you if you find yourself in a scenario where you need advice or next steps on who to contact. No question is too small. Seriously, no question is too big either. Thank you for watching our webinar, and I hope it has sparked some questions you feel comfortable bringing to the community conversation on April 3rd. See you then.
Thank you so much for including me in this important community conversation and thinking to include perhaps the unexpected topic of hematology. I have no disclosures to report. I'd like to start with a refresher or introduction on bleeding disorders, which are acquired or hereditary disorders that are characterized by the body's inability to form a blood clot. There are 13 different clotting factors in the cascade, and one may be defective or deficient in any of these to have a bleeding disorder. The symptoms may be spontaneous and include nosebleeds, bruising, extended bleeding with minor procedures like minor cuts or blood draws or vaccines, or a minor surgery or dental procedure, bleeding into their joints, muscles, and soft tissues. Though that history was taken from the National Bleeding Disorder Foundation, which is an important and very useful advocacy group if you ever do encounter a patient with a bleeding disorder. But also you'll see that there's a unique organization called the Foundation for Women and Girls with Bleeding Disorders, which particularly highlights some of the challenges encountered during the menstrual cycle and throughout reproductive life stages, such as pregnancy, childbirth, and menopause, which we're going to talk a lot more about. Because overall, we don't talk about periods. That is a very collective we. In fact, a 2017 survey of over 10,000 people found that 56% would rather be bullied than talk about periods. And 41% of parents with premenstrual children had never had a discussion about menstruation with those children. Those statistics were pulled from this paper, Sexism in the Management of Bleeding Disorders, by Dr. Wyand and Dr. James. And I highly recommend it if you are curious about some of the history of stigmatization of the menstrual cycle and some more of these really important statistics. They also point out that only 4 out of 10 women experiencing heavy menstrual bleeding will seek care for it, and that less than 10% of pediatricians and family medicine physicians will document a full menstrual history during a just basic well adolescent visit. The authors, in fact, did a PubMed search for menstruation and identified less than 4,000 publications within the last decade. However, a similar search of the word semen pulled up over 15,000 papers, which just highlights some of this discrepancy collectively, right, within the medical community, among people. And I think I want to highlight the fact that even if you don't work in prenatal or hematology, you can still have a hand in correcting or ending some of this stigma. Anyone who takes a personal or family history can address a menstrual or bleeding history, or at the very least, like please talk with your friends and family. You know someone who's menstruating or has the ability to menstruate and can normalize some of that stigmatization. I think they had a really nice image here of just how sexism leads to menstruation being stigmatized, Patients and providers are both kind of unaware of what constitutes a quote unquote normal period. And then bleeding disorders are underrecognized and underdiagnosed. And resources are then dedicated to individuals who don't have the ability to menstruate. And then symptoms and diseases are only recognized in them. Here's a real life case example from our pediatric hematology clinic. We had a 14-year-old adolescent who was referred for anemia and a history of heavy periods. And I just have to stop right there and say that is the ideal scenario, and that does not usually happen. I have to give the primary care physician a lot of credit for recognizing this history of heavy periods, thinking to order a blood count that identified the anemia, and then thinking to refer on to hematology. And I feel like that first step is the biggest barrier in identifying and diagnosing these patients. So this patient has 6 healthy full siblings, most of whom are adults. One adult sister also has heavy periods. And then their mother reports quote unquote normal periods, but then also shares this history that she required multiple blood transfusions after having each of her children. And so this history overall is concerning for an underlying bleeding disorder in the family. You'll see here a diagram that we pull out in clinic. So our physician did that with this patient to better measure what they're meaning when they are talking about their periods. This is an example of one of many that are out there and available online for your use. You'll see that they highlight, the use of pads or tampons, differentiating between if they're, thick nighttime pads or regular tampons or super plus tampons, and then the extent to which they're filled with blood. It's depicted as red blood, not blue liquid like you see on commercials. Though I note now that there's even more popular menstrual products that are not represented currently by these measures, like period panties. But using this, our physician was able to take this menstrual history on our patient, that she reached menarche at 11 years old. Her periods are regular, occurring every month. They last 5 to 7 days. On her heaviest days, she changes her super absorbent pad every single hour. Endorses flooding, meaning she's bleeding out of that pad even every hour, passing clots the size of quarters throughout her entire period, and feeling lightheaded most of the time. She denies any easy bruising and only has occasional nosebleeds. So based on this history, our physician ordered a typical workup for a bleeding disorder, which identified that this patient does in fact have von Willebrand disease. That is the most common bleeding disorder, affecting about 1% of the world's population. Based on that, our physician was able to treat this patient with an antifibrinolytic medication known as TXA. There's several brand name options, medication options, that help stop the bleeding by slowing the breakdown of blood clots. This patient was also offered hormonal contraception, which she declined, and is a standard part of our practice to offer it. And knowing that that opens up a whole different discussion about reproductive rights and some of the stigma around hormonal contraception and a lot of misconceptions we hear about it. But maybe that's for another time. Our nurse coordinator and our social worker gave this patient a school note because she was embarrassed to ask to go to the bathroom more than once an hour. There was actually really strict policies that prevented her from doing so, and she didn't feel comfortable advocating for herself. Also note that this was a Spanish-speaking family, and I think having the note helped empower the patient and her mother to advocate to the school in a way that they maybe didn't even know that they could, or feel that they were able to based on a language barrier. And then ultimately, we also referred the parent and the siblings for evaluation based on the history that's concerning that they may also have von Willebrand disease. I want to pivot from periods a little bit and talk about some of the other reproductive rights access issues we've seen in pediatric hematology based on my 2 different settings, or 2 different cases that I think highlight some of the same points. Here in Seattle recently, we had a pregnant parent who was affected with von Willebrand disease travel to Seattle from Montana. In Seattle, we cover a very large geographic region, Alaska, Idaho, Montana, with various levels of access to high-level specialty care. So this pregnant parent traveled to Seattle because her fetus was affected by a congenital heart defect, which required urgent surgery at birth. And actually, we were called in hematology to consult for the bleeding risk to the fetus. Von Willebrand disease is an autosomal dominant disorder. Thus, the fetus had a 50% chance to inherit it. And so they were calling us to ask about the risk to the baby. What's the chance the baby's going to bleed during surgery, which our hematologist, nicely spoke to, but then raised the question of what is your bleeding plan for the parent? Because we know pregnant people with bleeding disorders are at increased risk for postpartum hemorrhage, and there are very nice national guidelines for treatment and management involving a multidisciplinary team. And so I credit our hematologist for advocating for the involvement of a home adult hematologist. Pick up the phone and call Montana and make sure you're thinking about the parent and the child during this childbirth situation. On the flip side, when I was practicing in Texas, I had a pregnant parent who was a carrier of hemophilia who ended up traveling out of the state due to laws and regulations at the time to pursue a pregnancy termination of an affected fetus. And actually, that parent did experience a hemorrhage during that termination procedure, and there was no hematology care available or planned during that procedure because they were already kind of fleeing the state to have access to it. And frankly, I don't think even thought to mention their own history, their own risks. And we didn't hear about it until after the fact because there was so much stigma associated with pursuing that procedure. I think this person's life really was at risk. I look forward to our discussion, but in the meantime, I hope that everyone can take away that we can all be advocates for reproductive rights, and that might look a little bit different depending on your setting. That said, everyone can talk about periods. Please do so. Let's normalize that conversation. And hopefully, I think across the board, all of our panelists are advocating that we each work with community resources and a multidisciplinary team to ensure we're all advocating as best we can. Thank you.
Hi, my name is Pilar Magulis, and I'll be one of the panel speakers for Acknowledging the Discomfort, Discussing Reproductive Justice Beyond the Prenatal Clinic. I have no conflicts of interest to disclose. And just a brief introduction. So I am a pediatric genetic counselor and associate professor in the Department of Molecular and Human Genetics at Texas Children's Hospital and Baylor College of Medicine. I received my master's in genetic counseling from Northwestern in 2003 and currently work as a pediatric genetic counselor and serve as the Division of Genetic Counseling Chief for Baylor College of Medicine. I also serve on several different scientific advisory boards and board of directors for various organizations, and this is really where I have a lot of passion, is my advocacy work and really helping families throughout the genetic diagnostic process. And so I'm going to present two cases today that I think highlight some of the challenges that I've encountered in the clinical setting and also in my advocacy work, where I've had to have some of these conversations from a different perspective. So my first case is an example from my work with the advocacy organizations. And so this was a couple of years ago now, but I received an email from our executive director of this organization, and she wanted me to talk to a family who had received a prenatal diagnosis of this particular condition. She had already spoken to the couple several times and given them a lot of information about the condition and as a parent, but she felt that she needed, she wanted to have me discuss it with them, given my role as a genetic counselor who also works closely with these families. And so the couple was currently uncertain about their plans for the pregnancy, and they wanted more information. And so I requested and obtained the genetic test results that did confirm the diagnosis before setting up a time to meet with the family, just to make sure that we had everything documented. So this patient was 20 weeks pregnant, and this was her second pregnancy. She had an older daughter who was, I believe, 2 or 3 years of age at the time, and she had prenatal screening. So she had NIPT that was screened positive for this diagnosis, and then an amniocentesis was later performed, which confirmed the diagnosis. And so we had both the NIPT and amnio results, which confirmed the diagnosis. So with that information, I met with a couple over the phone several times over the course of a couple of weeks. And so I reside in Texas. They lived in a different state. And so we did this over the phone. They had a lot of questions, and even at that time when I was talking to them, I could sense and feel the turmoil that they were feeling with some of the decisions and what they wanted to do. This was a very wanted pregnancy, and the idea of possibly even not continuing was not something that they had ever thought of or would ever have thought to even consider. And so they had a lot of questions about the severity of the condition, just the features of the condition, day-to-day life, medical complications that might be expected, quality of life of individuals with this condition. On one of the calls, they had one of their friends who was a physician that also sat in, who had some good questions, and I think that was helpful to have sort of another set of ears to kind of ask questions and to hear the information. And so I got a sense at that time they were just sort of absorbing all the information that they could in order to make the best decision for their family. A few days after our last conversation, they did inform me about their decision to end the pregnancy. And at this point, I still, wanted to help them as best as I could, and I did not want to rely on our advocacy organization. I think that's a very difficult position to put them in. But I contacted my prenatal genetic counselor colleagues. One, because this is not an area that I'm familiar with, particularly with regards to abortion laws in other states. I didn't know what resources and referrals were needed. Also, just how to communicate about this. I was, this is an area that's somewhat out of my comfort zone, and I don't have these conversations all the time. And so I wanted to sort of get their advice on, how do I best communicate this information? And so I contacted one of our prenatal genetic counselors. She said, we have colleagues in this state. I'll reach out to them. They gave us information. They gave us resources for where the family could go. And so it was incredible to have that network of GCs to help me in an area where it's just not as familiar. Some of the other things that we did was, giving them some resources on termination and pregnancy loss for couples who make that decision. And so I sent the family some books and information afterwards, and followed up with them afterwards as well, just to kind of check in and see how they were doing. So some of the key takeaways from this particular case for me is I felt that I was in a somewhat unique perspective. On one hand, I am a board member of this advocacy organization, and so I work very, very closely with these families, with the parents, with individuals who have these conditions. And so I have a personal connection to them, as well as a professional connection as too. And so I feel like I do have a broad understanding and awareness of some of the joys and challenges that individuals can face. And I will say that this couple did meet with a genetic counselor during the pregnancy once they got the results, but they acknowledged that that genetic counselor was not as familiar with the condition, and so that's why they had reached out to the organization. I also felt internally maybe some twinges of guilt if they decide to, not continue the pregnancy. What does that say when I work so closely with these families? Does it mean that, their lives don't matter? And so I had these sort of mixed feelings from that. But at the same time, as a genetics provider, I do have knowledge of the medical complications, the risks, the comorbidities, and I think to present sort of a balanced picture of what one might expect if they have a child with a condition, highlighting the joys and the hopes and all the ways that that child will bring, joy to the family, but also that it's not going to be easy and that there will be challenges, not, there will be based on the condition and what we know about that particular gene. And so as a provider, I have the need to give balanced information and objective information so that that couple can take all of that and make a decision that is best for their family. One of the other key takeaways from this is, utilizing your network. And so I felt very much sort of outside of my comfort zone. One, discussing, I'm in pediatrics, and so I'm used to talking to couples and families when the child is there at the appointment. Physically, I'm looking at the child, and the discussion that we have is about what do we need to do for management? When do we need to refer the child to? And so my tone and my conversation about in a pediatric setting is about a child who's currently there, whereas in prenatal, it's about the fetus or the unborn baby, and it's a different kind of conversation, I feel, and I didn't want my sort of colloquialisms about talking about the baby and the child to maybe be misconstrued or, inserting any kind of judgment into when I'm talking now about a fetus and an unborn baby. And, sort of the language that I use is different in a pediatric setting versus a prenatal setting. And so that was somewhat difficult for me, but I really, again, utilized my network, stepping outside of my comfort zone to identify resources, other prenatal GCs in those states, in the state where the family lived, and resources outside of the state where they could go based on the gestational age. And again, using our prenatal genetic counselor colleagues to help with those state laws and regulations, what I cannot say, or should not do, say, and documentation, because this is, again, not an area that I am very familiar with and really haven't done much. My second case is from the clinic, and so this was an older case, but this was back in 2011 actually. So we saw an 8-year-old male on the consult service, and he had a history of progressive hearing loss, decreased visual acuity, behavior changes, regression of fine and gross motor skills, and his family history was negative. He has a maternal half-sister who was 6 at the time, and she's healthy. A brain MRI was done, which revealed leukodystrophy, and this was suggestive of X-linked adrenoleukodystrophy. And so genetic testing was done, which confirmed a pathogenic variant in the ABCD1 gene in the child, and also his mother, who was identified as a carrier of this condition. And so I had remained in contact. So we, followed this child in clinic, and then he was followed in neurology. And so I'd remained in contact with the family over the years as his symptoms progressed. And unfortunately, he passed away about 3 years later in 2014 at the age of 12. Later on that year, mother became pregnant again and contacted me literally a few days after a positive pregnancy test. And so she contacted me on a Tuesday, and she had just taken the pregnancy test that weekend. And so she must have been, she said, maybe 3 to 4 weeks. Like, she had just taken the test. She hadn't met with an OB yet to confirm the pregnancy, but she was panicked and very worried. She did not want to go through the same thing. She just lost her son with this condition and didn't want to have another child with X-linked adrenoleukodystrophy. And so at that point, I provided her resources, again, utilizing my network of prenatal GCs, help facilitate a plan 1 to get her in with an OB. We need to really, have that conversation first, and 2, refer to prenatal genetics for additional counseling and diagnostic testing. Fast forward to 2022, so a couple years ago, and this is now 11 years after the initial diagnosis, mom calls me again, and she's in a panic. Her daughter, who is the patient's maternal half-brother, who was 6 at the time, she's now 17, and she is pregnant. They are very, very worried about this pregnancy. The daughter has never had carrier screening. Again, she was 6 when we saw her, and so we wouldn't have offered carrier screening at that time. And still, technically, she's 17 now. Technically a minor, but now she's pregnant. One of the things that was very important for this when the mom called me is that, she and her brother were very close. They were only 2 years apart. She watched her brother, and this is what she told me, she watched her brother die. And this is something that she does not want to have to go through, and she is very scared. And so the mom called me kind of in a panic. What do we need to do? How do we And so, again, relying on my prenatal network, I contacted our prenatal GC team really to determine the best approach. Should we in pediatric genetics get carrier screening started just for the ABCD1? Let's just, get things going. Should we refer to them so they can have more of a discussion about all the carrier screening options, prenatal screening, diagnostic testing? What about the timing of the appointments? How much should that factor into our decision about whether we should just get carrier testing for the X-linked ALD versus sending them to prenatal, insurance coverage, the timing of getting the test results, all of these things. And so with that collaboration, we were able to get the patient into prenatal genetics very quickly, and she had known familial mutation testing for the ABCD1 variant, and fortunately she was negative, and so she was not a carrier. And so this provided huge relief for this family. And so some of the key takeaways from this case, I think are really still continuing to serve as a resource for families even years later. And so that family still had my email address 10, 11 years later. And so they were able to contact me to reach out even without knowing where else to go, and to help facilitate contact and referrals to the appropriate specialists. And so I think this is really important role for genetic counselors, is to continue to serve as a resource for your families. The importance of genetic testing discussions with the family, especially for X-linked condition and for those siblings. You know, when we saw the child initially, we weren't thinking about carrier screening for her because she's a minor, she's only 6 years old. But then she, got older and we lost contact because the child passed away. But I think this is something where we really need to try to stress this at that appointment, at subsequent follow-up visits, and with the siblings themselves, the importance of checking in with us, because we, hopefully, it worked out in this situation, but we want to try to catch that a little bit ahead of time so that there's proper planning that can be done ahead of time. And again, utilizing your network. And so recognizing the timing and the urgency of the referrals, both when mom contacted me about her pregnancy, and then 10 years, 11 years later when she contacted me about her daughter's pregnancy, they were both very, very early. And so that was helpful, so that we can get them plugged in very early for, prenatal screening and diagnostic testing. And then I think the collaboration and the collaborative relationship that we have with our pediatric and prenatal team, it's always been very helpful, where we can share the genetic information, we can share, what's our interpretation of this variant, if it's a VUS, if we think it's, likely the cause of the symptoms. And so this is really important for utilizing your network and your prenatal GCs, especially when you might be in a position where you don't always have these conversations, and they can really be a resource for you. And that is my contact information, and thank you so much for your attention.
My name is Katie Lang. I'm a cancer genetic counselor at the Vanderbilt Ingram Cancer Center in Nashville, Tennessee. And today I'm here to provide the cancer genetic counseling perspective on discussing reproductive justice beyond the prenatal clinic. To provide a little background on this topic, I wanted to review what we know about cancer and pregnancy. About 1 in 1,000 cancer diagnoses will occur during a pregnancy. Recent research has actually found that the rates of breast cancer diagnosed during pregnancy are actually increasing, but other cancers that can be seen during pregnancy include melanoma, cervical cancer, lymphomas, and leukemias. Before Dobbs, between 9 and 28% of individuals would choose to terminate a pregnancy after they were diagnosed with cancer. It is understandable that cancer treatment is very time sensitive. Research has found that every month of delayed treatment is associated with a 13% increase in mortality risk. So any delays related to getting an abortion is only going to exacerbate these even further. Cancer treatment can be divided into different categories. Systemic therapy is classically considered chemotherapy, but more recently, there are other targeted therapies that are given to patients that may improve outcomes, have lower toxicity. So these are actually very desirable for patients. However, given the targeted nature of these therapies that can interrupt things like cell cycles and dividing cells, they may be seen as more teratogenic than a standard chemotherapy. So one evidence of this are drugs that are considered DNA damaging agents. And these actually might be therapies that patients come to genetic counselors to have genetic testing to see if they're eligible for. So patients that have to remain pregnant during cancer treatment may not be able to access the most recent cancer therapies. Another newer type of therapy is immunotherapy. There is data that this type of therapy may interact with the maternal-fetal immune relationship. And lastly, chemotherapy, kind of the classic cytotoxic chemotherapy, has been used for a long time during pregnancy. There are some associations with low birth weight, stillbirth, and preterm labor. But most importantly, even if chemotherapy is able to be given to a pregnant patient, it's usually not initiated until after the first trimester, closer to the 14th week of pregnancy. So if somebody finds out they're pregnant very early after their diagnosis, this could still represent a significant delay in their treatment. Additionally, surgery and radiation are components of many people's cancer treatment. Depending on the type of surgery, it may be safe to do while a person is pregnant. But if you imagine a scenario where someone has a cervical cancer diagnosis, it might not be possible for them to have surgery and maintain a pregnancy. With radiation, there's almost no amount of radiation that would be considered safe during a pregnancy. Again, decisions may be made case by case, but many patients may be told to wait until they deliver to proceed with radiation therapy. So in the post-Roe world, there's estimates that approximately 1,500 individuals per year will be diagnosed with a pregnancy-associated cancer in a state that has banned or severely restricted abortion. So many people probably immediately consider, when we're talking about cancer, there are already many pre-existing long-held disparities in this area. And we also can see before our eyes that the states that are enacting these abortion bans overlap very strongly with the states that already have the worst cancer outcomes in the country. Post-Roe, about 39% of people who can become pregnant will have to travel up to 250 miles or more to obtain abortion care. We already know that communities of color and low-income communities will be disproportionately impacted by both the geographic divide and the difficulty in getting cancer care in the first place. So combining these factors, we know that both of these disparities will only be worse for these populations. This map highlights this. It's a little bit tricky to read, but essentially if you focus on the states that are in blue, those have the highest rates of cancer death. And if you look at the states with the horizontal lines, those are the states with abortion bans, and the states with the dots are those with prohibited abortion. So if you look, many of the states with the horizontal lines are blue, and some of them are red. States that are red have the second highest rates of death. So this is just showing that these bans are happening in the states where patients are already dying at the highest rates from cancer. This can also have a long-term impact on cancer care. So as it stands now, and probably always will, pregnant and breastfeeding people are usually excluded from clinical trials because it's not clear what could be safe for the patient or the fetus. But patients who are forced to continue their pregnancies will not be able to enroll in clinical trials, which in some case may be their best hope of a cure for their cancer. Additionally, clinical trials typically require documentation of regular pregnancy screening. And given what we know about the way data can be used by some of these states' governments, patients may fear having this type of data recorded. Even if they're not pregnant now, they may not want this type of thing recorded in case they become pregnant in the future. So the reality of all of this, right after Roe was overturned, Ohio's abortion ban went into effect. Within 2.5 weeks of that happening, there was already a lawsuit being generated to try to overturn this ban. And through that lawsuit, there were affidavits that were gathered by healthcare professionals of stories of patients who needed abortions and couldn't get them. And 2 of those stories were of cancer patients. One was 25, one was 37. One had stage 3 melanoma and found out 3 days after Roe was overturned that she needed an abortion. The other was in the middle of treatment, and both of them had to leave the state, pause or delay their treatment to obtain an abortion and come back to Ohio. And another aspect of this is to think about any person seeking an abortion in a state like Ohio is going to need to go to a neighboring or close by state. And so these cancer patients may encounter waits just to get the abortion, even if they can leave the state. They may have week-long wait times, which all the more delay their return to start their cancer treatment. Another thing to consider is in some of these states that are trying to find loopholes or exceptions to their abortion laws, or people trying to pass those to at least provide some relief for patients. How does a delay in cancer care factor into an exception like this? The timeline of survival and treatment varies drastically depending on the type of cancer. So for something like breast cancer, Typically, a cancer in your breast is not an immediate threat to your life. It is if that cancer is able to metastasize and spread, that cancer no longer becomes something that's curable. So the imminent threat is really not necessarily there. It is the long-term threat to your health and your lifespan, where other types of cancers like leukemia in the very short term require close to immediate treatment, or they can become life-threatening very quickly. So these things are hard to define, and there's not one size fits all for how to define an exception to one of these laws if someone were to do that for cancer patients. And then on top of that, there's the risk to the doctors. A doctor who prescribes a chemotherapy or performs a surgery on a patient who is pregnant and that patient has a miscarriage. How will that be treated? Would that be treated like they provided an abortion? And could they be penalized or criminalized for that? It's all very nebulous right now. So what is the role of a cancer genetic counselor in this evolving world? I think we need to be aware that our patients may be impacted by these abortion restrictions, especially since a lot of the people coming to cancer clinics might be younger cancer patients. They may be facing pregnancy, they maybe were trying to get pregnant, or they may find themselves pregnant soon after diagnosis. Make sure you're familiar with your state's laws and your institution's policies around what you can say and can't say about abortion. Every state is different, and these laws are changing quickly. Most of us might have prenatal colleagues, like I'm lucky to have with like Sam, who have educated me, but you should always be familiar with what's going on at your institution to make sure that you don't cross a boundary that could get you in trouble. We certainly have the skills and the empathy and the understanding to talk to these patients who may be facing these decisions that are absolutely unimaginable. Make sure you're still operating within your scope of practice or your credentialing, but most of these patients may just need an understanding, ear, and we can certainly provide that. And then see if you can identify colleagues, who maybe are in the prenatal space at your institution or elsewhere, because that's maybe a place where our oncology colleagues are not used to referring people, but maybe we can make them aware that these conversations are ones that they are particularly equipped to have where our scope might end. And I look forward to joining more folks in the breakout rooms to talk about the role of cancer genetic counselors in this new world post-Roe. Thank you.
And with that, I want to thank you all for attending this lecture. You are welcome to register for the live discussion at the QR code here or sign up on the Community Conversations website under the Member Webinar tab. I hope you found today's lecture informative, and I hope to see many of you at the live Community Conversations on April 3rd at 4 p.m. Central Time. Thank you so much.